The broadcast is now starting. All attendees are in listen-only mode.
Good evening and good morning for some of you. Welcome to the webinar on the health economic benefits of fracture liaison services and how to make a business case. My name is Masaki Fujita. I am the Science Project Coordinator at the International Osteoporosis Foundation in Switzerland. I am also the Global Program Coordinator for the Capture the Fracture program. It is my pleasure to run today's webinar with our speaker, Professor Kasim Javaid. Professor Kasim Javaid is an associate professor in metabolic bone disease, Nuffield Center of Orthopedics, Rheumatology, and Musculoskeletal Sciences at the University of Oxford, UK. He is an expert on secondary fracture prevention and implementing FLS, and he is also the current co-chair of the Capture the Fracture Steering Committee. Before we begin, I'd like to inform you that all attendees are automatically muted. If you have any questions, please type your questions into the question box of the panel. They will be collected throughout the webinar, and we will voice them towards the end of the webinar. Now on to you, Kasim, when you're ready, please.
Thank you very much, Masaki, and welcome everyone to this webinar. Masaki, am I coming across loud enough?
Yes, perfect.
Thank you. Okay, so we're going to discuss in the next 45 minutes the health economic benefits of FLS and how to make a business case. These are the views that we've gained from our experience of running the CTF program and also the work we've done in the United Kingdom. Here are my disclosures. So in summary, by the end of this webinar, you should be able to have a good overview of the Capture the Fracture program, how to describe the benefits of the FLS, the costs, and then what does a good business case look like. So just for those who are unfamiliar with the Capture the Fracture program, this is a global flagship program within the International Osteoporosis Foundation, launched in 2012, with the aim of implementing FLSs that are effective across the world to reduce secondary fractures. This is delivered through a global voice, driving national and international policy, quality, and for this webinar, providing support to help FLSs get funded, get started, improve, and achieve sustainability. CTF program is co-chaired by myself and Professor Christina Ackerson, with the other members you can see here. So if we just stand back onto fracture liaison services, they fit into a program of osteoporosis care. At the top, we have inpatient care of hip fractures, and we know that better quality of hip fracture care in terms of time to surgery, multidisciplinary input, leads to cheaper and shorter hospital stays with better patient outcomes. Then in the blue, we have high-risk primary prevention, and in green, healthy aging. And secondary fracture prevention, as this small proportion of the population actually leads to about 50% of all hip fractures. However, we have recognized, and as you all know, if you're on this webinar and have tried to implement an FLS, FLSs are complex. They're complex for two reasons mainly. First of all, they cross specialties, and secondly, they cross the hospital and community care divide. To be effective, an FLS has to identify patients, systematically investigate them, take appropriate treatment initiation, and then in conjunction with community providers, deliver ongoing monitoring and fracture treatment and fracture monitoring. It's only through completing each step of this crucial chain can we actually realize lower refracture rates and the healthcare savings. When we look at the CTF map, there are impressive results: 271 FLSs, 38 countries, 6 continents. But even within the countries with high levels of FLS, there are still many sites that do not have a fracture liaison service. So how do we get more FLSs set up? And this can be divided into 4 stages. And in this webinar, we'll talk about political prioritization and getting funded. And the main hurdles to getting more FLSs funding is the lack of political prioritization, the lack of evidence for what is a clinically effective FLS model, and the lack of true robust evidence for what is a cost-effective FLS model. To tackle the first issue around national prioritization, it's important that within each country, the national benefits of FLS are truly described as well as the costs. And this will then allow decision makers to position an FLS nationally with other competing services. So in summary, we need the benefits, the volume, and the service resourcing at the national level if we want to get FLSs prioritized nationally. So in the UK, this was done through a coordinated effort led by the Patient Society, the National Osteoporosis Society, linking together government bodies for both public health and hospital care and primary care, with professional societies for geriatrics and orthopedics, with the Royal College of Physicians providing a quality framework. And we need this coordinated approach to FLS at the highest level if we're ever to get at the national level prioritization. And this is important when these decision makers are prioritizing against other diseases such as cancer care, lung disease, trauma, obesity, diabetes, cardiovascular disease, or infectious diseases. Because for them, the priority is to reduce premature mortality in the young. That's the overwhelming priority from WHO and from other areas, prevent premature mortality. However, it's becoming increasingly important and apparent that preventing avoidable morbidity in the elderly is equally as important. So in the next few years, there'll be a tremendous increase in the number of the elderly, and this will reflect an increase in the number of hip fractures up to 2050. And it is highly likely that unless this demographic shift leading to a large increase in hip fractures is dealt with effectively, then the impact on the healthcare system's ability to provide healthcare to prevent premature mortality will be diminished. And in this way, with a joined up approach, we can actually prioritize FLSs, both in terms of outcomes at the patient level, but also for the healthcare system. So where can you find this data? Well, we're very lucky in Europe. Work by John Keynes's group has developed a sort of European scorecard, and this is about to be updated with the EU6 report, which should be out later this year. And here you can see the figures for the UK, and it gives, in 2010, there were just over 500,000 fractures in the UK, at the top red arrow, and this translates to a total cost of 4.4 billion. And as you can see, most of this 4.4 billion, in fact 3.2 billion in the bottom line of the bottom arrow, was actually from a first year of hip fracture care. Using this data nationally, we've been able to then estimate it for England and Wales if one was to implement effective secondary fracture prevention to all eligible patients. You're looking at preventing about 54,000 fractures within the first 5 years, and a saving of 150 million just from the hip fractures alone. It's important when you are doing these cost estimates not to forget the other fracture types. And we know from growing data sources that actually hip fractures make up from 40 to 30% of the total fracture cost, with a significant fracture cost from non-hip fractures, as you can see here, in terms of hospital costs, rehabilitation costs, and nursing home costs. So by collecting this data and putting it in a format that policymakers can agree to and can accept as robust, one can develop the political prioritization to demonstrate the benefits of an FLS. So what about getting funded? We now have to transition from the evidence, from the trials, and from the health economic data to a more pragmatic approach to getting funding. And the key step here is to know your audience. We like to think of 3 key audience members in this process. In the top in green are the decision stakeholders. These are the people who decide that an FLS is a priority, either locally, regionally, or nationally. They may be distinct from the people in blue who actually pay for the FLS. So one may have to tailor the message and a different approach to let the people who pay for the FLS prioritize it. And finally, we need to know who's going to benefit from the FLS, and to do that, we need to know who's paying for the fractures. And this is one of the problems with FLS, is the people who benefit are often the people who don't pay for the FLS. So, for example, the benefits are clearly for the patients and family, often in community care and social care. The costs for the FLS are usually borne by specific departments in the hospital. Another sort of indirect cost is the argument we sometimes hear that if there is an effective FLS put into the healthcare system, then there'll be lower emergency admissions and we'll lose income from trauma admissions. I think we need to be quite forward in this as a community, because what this argument is actually demonstrating is that the healthcare provider is purposefully not treating patients so they can fracture again. And it seems interesting that whenever I rephrase that comment into the second comment about not treating patients so they can fracture again, I have yet to find a single orthopedic surgeon or hospital manager who's willing to put their name to that comment. And I would really welcome any feedback on this from your local experiences in the questions. So when we're looking at who pays for the fracture, really one needs to map out the fracture history pathway for the patient. From fracturing at home to attending the hospital emergency room to imaging diagnostics, and either they're discharged home, discharged to the clinic, or admitted to the hospital. And these costs will vary by fracture type and also by setting, whether it's a government, private, or family. And one can times this by the total local volume, one can get the help get towards the cost saving. And we do this through a benefits calculator, and I'll give you some examples later, but the benefits calculator basically takes the input of the number of fracture patients at these common sites, hips, spine, and non-hip, non-spine, and then using national data on refracture rates, the fracture costs, can work out the benefits. And this is intimately linked to the expected refracture rate and then the estimated avoided fractures over a 3 or 5 year window. However, the work isn't done then. It's then very important, in fact critically important, that the expression of how avoided fractures are communicated to the provider or the payer or the stakeholder is very carefully done. For some stakeholders, avoided fractures isn't enough. For others, it may be ambulance visits, emergency room attendance, hospital admissions, theatre time, bed days, hospital costs, rehabilitation costs, or care home costs. And it's knowing what this sort of currency of the benefits of FLS will need to be that is really critical for a successful application. One can then model for, say, if you have 300 hip fractures a year, we estimate there'll be 1,500 total fragility fractures a year, and you'll be seeing a proportion of these. And then if you can work out for your own local care setting what the estimated case finding rate is, so how many of the hip fractures, spine fractures, non-hip, non-spine fractures you find, how many attend the assessment, how many you'll actually initiate treatment on who don't have contraindications, what is the 1 year adherence rate. I haven't seen this yet, but some sort of adjustment in mortality may be needed in some settings. And then importantly, what's the expected 3 to 5 year refracture rate? And from this, we can get the avoided fractures. So for every 300 hip fractures per year, 1,500 patients screened, you're looking over 5 years to prevent about 300 fractures, from which just under about 40% are hip fractures. And this is calculated using the United Kingdom business calculator, which is available freely online. And then if you bring in the costs, you can actually work out, this is the figures for Mexico, how many, what are the cost savings? And here I've worked them out for in terms of healthcare costs and admissions. But to do this, you need the hip fracture healthcare costs, which are usually quite easy to know. They're usually published in the country and they're quite easy to assemble. For non-hip, non-spine admission costs are difficult, as are the outpatient costs. Some systems do put in the DEXA lab and drug costs. We don't tend to, because they often blur make it difficult to understand what's the benefit of FLS versus benefit of the healthcare system. But then definitely the care home costs, care home admission rates and social care costs need to be taken into account. When you do all of this, you can get these sort of figures for Oxford for 5 years where I work, population of 620,000. In red, I've circled the hospital savings at 5 years, which is 3.5 million. And then if you combine the primary, social and community care costs with the hospital costs, you're getting to cost savings of over £5.3 million over 5 years. And this is really important to do. Unless you can, in one sentence, summarize the estimated cost saving for your FLS, you'll find it very difficult to engage with policymakers about investing any sizable fund into your FLS. As I mentioned, these figures were derived from the National Society FLS Benefit Calculator. If you Google it, it's available online. It allows you to estimate the caseload, the DEXA rate, numbers prevented, and the costs that you've actually averted. And in this calculator, although it's based on the UK, you can change the data. You can put in different numbers of hip fractures, other inpatient fractures, other outpatient fractures and spine fractures. And from this, you'll get a report, as you've just seen, which will be the number of fractures avoided and the healthcare and social care costs. So those are the benefits of the FLS. How much does it cost to build an FLS? Well, the main cost of the FLS are for the specialist nurse time, the doctor, the administrator, the database, laboratory testing, DEXA, and drugs, which some include and some don't, and then the monitoring costs, times by the total volume to give you the cost of the FLS. And one question I often get asked is, how big should my FLS be? And this is very important to be clear, sustainable, and effective on. Because your FLS should be big enough to be effective. And the way we can tell if our FLS is effective is by quality and data benchmarking. Because there are a number of questions that an FLS has to, decisions an FLS has to make as it sets itself up. How will it identify patients using in-person face-to-face visits, which are more effective for adherence, or by using remote letters and correspondences, which have a lower adherence rate? How will you investigate patients? Will you ask them to come back for another visit where you may hit a barrier in terms of a higher did not attend rate, or do you try and embed it in the existing FLS pathway? Who initiates or recommends therapy? The balance of oral injectable therapies for initiation is important. And then finally, monitoring in terms of the method of monitoring, the site of monitoring, and the outcome of monitoring in terms of changing treatment recommendations. And as you well know, the IOF has set up a best practice framework, which at the facilities level audits the quality of an FLS in delivering across these domains. As well as effectiveness, I think it's important to also that the cost of the FLS should bear in mind that it should be as minimally disruptive as possible. Ideally, an FLS should be invisible to the patient and the trauma department, so the patient just considers this as part of their health care. There should be provided care close to home, considering a number of patients will be frail and will find it challenging to come back to the hospital setting. And it should embrace non-face-to-face settings such as postal questionnaires, telephones, emails, SMS, or app-like applications, all to make it as least disruptive as possible for the patient. So when deciding about who pays for the FLS, if we can construct a pathway that meets the IOF standards, make sure it's minimally disruptive as possible, and then we can develop a costing for every 100 or 1,000 patients, and then use this and then derive the cost for the FLS. And then we can then build this into our benefits calculator, so as well as the benefits of an FLS, it can derive the costs. And this is what's been done very successfully in the UK, and I'm aware of other centres such as JPAC in Japan and Asia Pacific who have also developed similar calculators. And the real aim is to have a really easy user interface where the user puts in population data, local hit data, or all fracture data, and then can export at the national, regional, local level reports on its effectiveness. And these reports will include, as I've already summarized, in blue, the inputs and outputs, and then in green, the sort of more detail in terms of the costs of number of patient assessments required, number of laboratory and DEXA scans, treatment recommendations, monitoring, and then the staffing, administrative, and database requirements to meet these demands, balanced against the currency of outcomes that are tailored towards the sort of payer that you're focused on. So that's really focused on the generic aspects of getting funded. But often there are local, regional, and national tips that need to be followed that can help improve the success of your business case. Unfortunately, these are very poorly taught in most medical schools, and most healthcare professionals are not formally instructed in writing business cases or delivering them. At the core of the business case is this balance between the cost of the service on the left and the deliverables of the service on the right. And it's important for the deliverables of the service, these are linked to key performance indicators, for which we've done a recent webinar on in 2018. As well as the core costs of the service, one should also look up at the setup costs for the service. Often these are quite expensive services, often running over £200,000 or €300,000 a year to be effective. And it would be sensible to explore whether your funder will include a project manager who will help set up the service, some sort of database or information technology support, and also some support for recruitment. Often it's an attention to the setup costs that will ensure your FLS gets off to a good start, as it is already challenging enough to set up an FLS. The first step is to find a champion. The clinical FLS champion doesn't need to be a clinician, they just need to be someone with some sort of healthcare experience who can provide overall leadership to the program. They'll be overall responsible for the management of the program initiation and delivery and sustainability, and provide the motivation and energy to keep the program going in the face of adversity or other challenges. In these sort of scenarios, I've done a sort of pragmatic split of the sort of skills the champion should have. Historically, this is really concentrated on those with the greatest clinical knowledge, but in our experience, actually, this can be a disadvantage in that too much clinical knowledge leads to overcomplicated pathways that can lead to disengagement from non-experts and make it difficult for the nurses to deliver quick and effective care. There needs to be a skill of the champion in experience in writing business cases, and if they have no experience, they should seek a mentor for this. A large part of FLS procurement is actually negotiation, where one proposes the initial FLS model and then is open to informative and constructive negotiation to deliver this. By far and away, an important aspect of this is time. Writing a business case sort of at the national, regional, local level takes time, and this is important. And without that ability to give that sort of time commitment, many services suffer from incomplete or inadequate business case proposals. So the first thing the champion has to do is their homework. The champion has to do their homework to see how the FLS program that he or she wishes to implement fits in with the rest of the healthcare setting in which they're working. They have to figure out who the key stakeholders are, competing services, supporting services, and what sort of meetings they need to attend to help build the momentum for getting an FLS funded. So the stakeholders we've described: decision stakeholders, benefit stakeholders, and FLS stakeholders. And so this is our stakeholder map for Oxford that we created. So we had primary care as a key stakeholder, pharmacy. For the payer, we had representation on their decision board, clinical representatives, and also awareness of their existing strategies and priorities for local healthcare delivery. At the hospital level, we're required to engage with a number of departments that interface with the FLS pathway, as well as hospital-based finance, coding for activity, and then importantly, estates and housing. So we need to know where, if an FLS was funded, the FLS would work and what sort of IT support they would get. However, the most important stakeholder are the patients, carers, and patient society. And if there's one success metric we had, well, it was patients. 2 of them came to every single payer meeting. They were part of the FLS development team. They informed the pathway, they informed the resourcing, and they informed the negotiation with the payer. And I think if you have failed to get an FLS funded, you cannot say that it is impossible to get an FLS funded until you have failed with a patient. It is very hard for a payer in front of a patient to say this is not a priority and leave it for other settings. So what are the other tips? I think one mustn't underestimate the administrative burden. This is a relatively straightforward pathway at very high volume. Some centres may have 1,000, some centres may have 3,000, some centres may have 10,000 patients to go through every year. Effective and efficient administration is really the heart of your FLS, and you need to pay attention and funding resource for this. This is split up into administrators and whatever healthcare database you have. The ideal healthcare database would have an assessment template that's systematically applied, easy to input into a database, and can output in the GP, primary care, or patient letter. They could also output into audits and quality improvement, referrals and requests, patient recall, patient information, and other additional GP correspondence. Another issue is the variability of FLS activity. And it's important to recognize that fractions do vary by month, sometimes even by year, but this variability can be quite marked, and you need to build in resilience to your system so that if needed, nurses can switch roles to support overburdened roles at short notice with good effect. And this often means rotating your FLS nurses so they know how to deliver each part of the pathway and therefore can step in. Another thing we don't get taught about at medical school is intelligent staff appointments. It's far better to choose to go for 1.2 whole-time equivalents, so you can have 2 nurses at 0.6 than 1 nurse overall. The reason for that, if you have 2 nurses who are part-time, they can cross-cover each other during annual leave. Don't forget to take into account when you're planning how many nurses you need, time lost or spent during mandatory training, annual and study leave, other roles they may have to undertake, travel to clinics, and succession planning and turnover of staff. FLS has been exciting places for nurses to work in. They're often given tremendous responsibility and are highly valued by the team, but they can be overworked, and it's very important we make the services very attractive for new recruits. Another aspect that's often neglected when we're developing a business case is piloting data. You're inputting a new healthcare system into an overburdened and overstretched existing platform. And it's really important to pilot what you're doing before you put in the business case to know that it can work in your hospital system. Often in the outpatients clinic, this can be very challenging, and often space is an issue. In the hospital inpatient setting, it's often which time of day is the patient available to be assessed by the FLS nurse, It may not be 9 o'clock in the morning when the clinicians are doing their rounds, maybe better off in the afternoon, but not interfering with visiting hours. Again, the aim is to make the inpatient and trauma not see the FLS and to make the FLS invisible. So what to pilot? I've already mentioned fracture clinic space and when to do the ward assessments, different methods of identification, of laboratory testing, and also when and how to incorporate DEXA. Another tip is to go for a staged implementation, and this is with staged funding. So you set up the core service, widen the case mix, collect the outcomes, and use this to inform service improvement. Often we start with one type of fracture, it's on the y-axis, so maybe hip fractures or other in patients, and deliver the entire service scope for this group. And once you've achieved this, then one can move on to the next level of case mix. And again, and because you've scoped out the entire service scope, you can accurately cost it. It's important when you're doing this, you work to key performance indicators, and we discussed this at our previous webinar. But by tagging your FLS activity to key performance indicators, you can match how they work. So now, without doubt, that FLSs are finding it difficult to be implemented in the real-world setting. It's not a simple process. An oversimplification of FLS runs the risk of it not being effective and jeopardizing long-term funding. So here were the FLSs before the audit, where everyone thought they were doing well. And here's the picture from the FLSs from the last audit, which is a publicly available document showing the variability of FLSs. Green is good, orange is okay, and red is bad across the different key performance indicators. And it's really using these sort of indicators that will drive quality improvement and get your FLS from being started to being improved and sustainable. Another tip is to shift the risk from the payer to the FLS. There's three sort of general funding models. One is funding on input. So the FLS is funded on the amount of staff. This has the advantage in that you know your pot of money you're going to get, and therefore can from the start employ staff for a fixed contract. The downsides of this is because of the aging demographic or changes in your healthcare system, you may get widely varying numbers of hip fracture and other fracture patients coming to your service. To minimize this, be aware that as your FLS gets better and more experienced, it will get faster. So what will take the time taken to see 100 patients at the beginning of your FLS will be a fraction of the time needed for 100 FLS patients after 3 years to be seen by your FLS. And that sort of mitigates that. The other one is funding on output, so the number of patients seen or the achievement of key performance indicators. This is useful for the provider in that the more patients they see and work harder to identify, the higher the reimbursement. The issues around this is very difficult to control staff appointments. They have to be relatively short term as changes in healthcare provision beyond your FLS's control could drastically change how many patients come to your FLS. Probably the most aggressive form of funding model is funding by outcome, and this is the one that we have experience of. And this is where the budget is reimbursed, a proportion of the budget is reimbursed based on achievement of KPIs. So you pay to deliver the service and you give some money back if you fail to deliver the service. The outcome measure must be easy to measure, robust and meaningful, and it must be scaled appropriately. Be aware that nothing is 100% in medicine, and so these are some very aggressive, what we would call aggressive KPIs for the service if one wants to go for a funding by outcome methodology. So although this seems like a lot of work, there is a lot of help available online, and the best place to go is to the IOF Capture the Fracture website. And under resources, there are a number of tools that can help you. There are slide kits and toolkits which will guide you through most of the processes involved in setting up an FLS. In the FLS toolkit, there are documents from understanding the need for an FLS, FLS implementation guide, the business case planning side, and the coalition guide. And it really gives a step-by-step guide to FLS planning and development, and how to get started and how to expand your FLS. Finally, we also have in the business case planning document a Word document, and I've made it this size deliberately. Everything in red you can change, but the rest of the wording and importantly the references in black are already provided. And it's really a matter of going through the document and tracking the changes and removing all the red text so there's only black text that remains. So in summary, I hope I've been able to share with you an overview of the Capture Fracture program, the factors you have to think about when you're thinking about the benefits and the costs of an FLS, some tips on what a good business case looks like, and a short guide to the tools that are already available in the Capture the Fracture website, as well as resources from other tools. I'd like to thank our sponsors for this webinar, UCB and Amgen, and I'm now happy to take any questions that you may have. Thank you very much.
Thank you very much, Professor Javaid, for your presentation, giving an overview of the health economic benefits of fracture liaison services and how to build a good business case. Now, you have also highlighted some of the key elements that are needed for a good business case. We did receive a few questions during the webinar, and I would like to voice a few of them to you, Kasim. So starting with number one, what can we do for FLS in countries where secondary fracture prevention policies are lacking and FLSs are almost non-existing? Where do they start, and how can CTF help with this?
Yes, this is really an important question. I think the first step is to find out how much information is already available. So number one, do you have a patient society? Number two, do you know how many hip fractures come to your hospital? The way most hospitals work, these should be easy to code up. And then from the number of hip fractures you've seen, you can do a very quick audit, and we're happy to provide you with those audit tools where you can actually calculate what's the length of stay of the hip fracture patients, how many of them were on treatment before they came in with a hip fracture, and even better, if you knew how many of them had a fracture before and weren't treated. And then what happens to them after they're discharged? They're going to expensive rehabilitation facilities, and really start from that seed in developing the hip fracture argument for setting up an FLS. And once you've got that data, it will take about 6 months to collect. You can then say to your hospital that you're spending this much money on hip fractures. We estimate this is the amount of money you're spending on other fragility fractures, and then have a go at working out, by putting those numbers into the benefits calculator, what an effective FLS will look like. Once you've got that at the local level, then it's about finding out with your patient society how you can get that informed at the higher decision-making level, in terms of at the national, regional level, what other healthcare savings we can achieve. That should keep most people busy for long enough to get somewhere with setting up their own FLS, Masaki.
Thank you very much for your detailed answer. That brings me to the next question. Now, what are the key differences between building a policy case in a business case? I believe some KPIs are stressed for both, and some are not.
So the policy case is about making the decision that FLS, or actually secondary fracture prevention or post-fracture care, is a priority for the healthcare system. And this involves political and decision-maker negotiations going in the national picture. The business case is actually the very detailed description of at the local level, what are the costs of setting up an FLS, what are the benefits of setting up an FLS, how you're going to set it up, how you're going to monitor that it works, and what you're going to do to make sure it becomes sustainable. So there's clearly an overlap between the two. but they have distinct purposes.
Thank you, Kasim, for your answer. Now, I would like to move on to the next question. Now, I think this is a question relevant to a lot of countries where the private healthcare system is dominates. So, in a private healthcare system, having more patients return to hospital with fractures is not necessarily a bad thing. Now, from the perspective of revenue, that is. Now, how do you convince administrators that having an FLS in your clinic is a good thing, not only for your patients, but also for the hospital?
Yes, I've got this, and it's kind of surprising that we still get this, but I understand why it happens. So I think there's two different approaches you can take. You can take the approach that patient outcomes matter most, and actually are you purposefully not treating patients so they can refracture and generate income for your hospital? Because if you are, can I have that in an email so I can discuss it with my patient society? A far more sophisticated approach is probably to go in to describe how the non-elective admissions are affecting the hospital stay. So, for example, if you work in a hospital that accepts both non-elective and elective cases, you really want to keep the non-elective cases down so you have time to do the more planned and more structured elective cases. So non-elective cases that block your beds, have significant comorbidity, and have operative complications. And those are the two main structures that I would use. One is that, are you really suggesting that you're purposely not treating patients so they fracture again? Or you can argue that by reducing the non-elective admissions, they can actually tackle the non-elective admissions and have more space for more lucrative elective admissions.
Thank you for your answer. So FLS improves refracture rate, saves costs, and it should increase treatment initiation rates and medication adherence rate. So I believe in this sense, the financial benefits should outweigh the costs.
Yes, it depends how you calculate this. The problem is that if you build an FLS to say that you're just going to reduce fractures and measure that, as I already mentioned, fracture rates vary a lot over time, by month and sometimes by year, and this can be up to 10%, and this dwarfs the reduction you'll get from the drugs. Over a long period of time, as the demographic population shifts, we're expecting, significant increase in the number of hip fractures. I would say successful FLS is one where the hip fracture rate is not increasing, and a very successful one is where it's going down. However, I would not base my FLS on this because a bad year or a good year could lead to false reassurance. It's far better to cost an FLS based on the KPIs of delivering drug to one patient at 1 year, because we know if patients take the drug for a year, there will be a reduction in their absolute risk of fracture.
Thank you for your answer, Kasim. Now, this is actually a question coming in from Chile, and it's actually related to a private healthcare system. Can you give any advice to be able to improve adherence in such healthcare systems?
I think that's a really important question, and we haven't found the solution yet. We are lucky in osteoporosis compared to other chronic diseases that we do have long-acting injectable therapies. Imagine if you could treat diabetes or hypertension with a 6-monthly or an annual infusion. I think the key, my personal approach to this is that in these high-risk people who are going to have an imminent risk of fracture, that if they can't tolerate oral treatments, the best way to do this is to identify this early and switch them to injectables as quickly as possible to ensure adherence. We do know that simple patient education does not work. So there have been a number of trials that have looked at giving different ways of information about osteoporosis, DEXA scanning everyone, feeding back the results. All of these processes have small, but probably not clinically important differences in adherence at 1 year. Indeed, the most recent FLS survey showed that Adherence at 1 year went down, not up, but went down after the FLS was implemented. So it is an issue, but those would be my key strategies.
Thank you for outlining the key strategies. Now, the second question from the same person, in fact, is where can they get tips for building databases regarding costs? And if you have any recommendation on softwares, I think this is a good opportunity to talk about this.
Yeah, I think that, so let's tackle the software. So I think we've had to develop our own software. It's not transferable to other countries. It's very complicated. It was built, it's old, it needs renewing. And we are looking for, I don't know if there's any industry representation on the call, but this is a key priority. Unless you have a good software program that runs your FLS, then you're going to be very much very challenged to do this. There are commercial products available, but these are often extremely expensive compared to the cost of the FLS, and actually are overcomplicating their modeling. In terms of the cost, it's really quite simple. Once you work out how many fractures you should be seeing a year, which you can work out by timesing the number of hip fractures by 5, that gives you a rough idea. And then you can work out it takes, 20 minutes to see the patient, maybe another 20 minutes to do the monitoring, the correspondences per patient, and then half the patients will need treatment. You can build up a per patient time cost. And then once you've done that, you can find out how many patients you have to see in a year, how many patients you can see in a clinic or in a session, and then work out how many nurses you need to deliver that platform. And this can be done quite easily on a spreadsheet or not with that much complicated software. The killer question is monitoring. If you do indefinite monitoring, eventually you will end up monitoring tens of thousands of patients. So you have to agree nationally what is the duration of monitoring before you don't monitor them anymore. And in the UK and in the CTF, we have gone for 1 year, with the assumption if you can have someone adherent on treatment for 12 months, they are highly likely to continue with treatment unless something untoward happens. Those would be my key points to working out the costs.
Thank you for your answer. Now, as we are running close to the end of the webinar, I would like to address 1 or 2 more questions maximum before we end this webinar. Now, Kasim, going to the basics. So, if an FLS develops a business case, can IOF or CTF help them make sure that this is of good quality? In fact, the question is, how exactly can the steering committee help in this manner?
Okay, so this isn't a role the CTF has traditionally done. I would say your first person to negotiate with would be with your local patient society. They will be a far stronger partner for you in developing your business case than we can, and they will help you make sure that it is actually a business plan that would work at the patient level. You can definitely submit a proposal to the CTF and you'll be loaded as a blue star, and you can use the stars in the CTF in your region to find out other FLSs that are in the network. Now, we have not made it mandatory for FLSs to share their business cases, as this may be competitively sensitive information. However, we do encourage FLSs to be collaborative and sharing in their approaches. And those, I think, will be the main ways that the CTF will be able to help business case. We're developing the key performance indicator panel, and once that's available, you'll be then able to use that to write your key performance indicators to build into FLS.
I think that is a very interesting point to make, Kasim. the blue star or obtaining a star via the Capture the Fracture program is a good leverage to seek funding and to support the development of business cases. Now, having said that, on that note, we do unfortunately have to close this webinar. So thank you again, Professor Kasim Jawari, for your fantastic presentation. And also I have to extend my gratitude for everyone who is attending today. And we hope that you enjoyed this session. As usual, we will post recordings of this webinar on the CTF website. Now you can find the webinar page on the CTF website under the webinars tab. Now after this webinar, you will be prompted to fill in a survey. Now this is voluntary, however, we would appreciate very much your input and comments as we will use your answers to construct future webinars. Now, last but not least, if you have any questions or comments, please do not hesitate to send them over to Capture the Fracture at iofbonehealth.org. Now, on that note, thank you very much again, Kasim, and have a good evening, everybody.
Thank you very much. Good evening, everyone.
Thank you. Goodbye.